So welcome. So we have today, I'm so excited. We had done this, I think in April it was, and Facebook was not cooperating. So I'm glad Zoom is coming through for us. But we're talking today with Dr. Maggie Gise, who is a pelvic floor physical therapist and is fantastic. And I've sent her so many people and they've all done really well and gotten better. So she's great. So I wanted to share more of what she does and who she is, because I think more women need to know about this. So thank you for taking time with us today to talk about what you do and answer all these questions.
Yeah, thank you. I'm very happy to be here.
So to start, some women might, maybe they've heard about pelvic floor PT, maybe from a friend, or it's becoming a little bit more well known, but could you just explain like what pelvic floor PT is for people that don't know?
Yeah. So pelvic floor PT, I would say, is a niche inside of physical therapy in general. But I would also say that it's a niche inside of orthopedics specifically. And so with pelvic floor PT, we have special postdoctoral training in the muscles of the pelvic floor, which can really only be palpated and fully assessed through internal examination. So we kind of take what we learn in school as far as biomechanics, movement, and apply that to a separate group of muscles, specifically the pelvic floor, that a lot of times in ortho and other settings of physical therapy gets missed and not like fully assessed. It's kind of like we don't really learn very much about it in school and it just gets forgotten. So there's this whole postdoctoral training for people specifically to learn how to assess this muscle group. And it's really important because it really is the basis of our function to our core. And that word core is used a lot, but like really when it comes to breath and pee, poop, and sex, your pelvic floor is the basis of all those functions. And that really impacts everyone's movement, even outside of the pelvic floor. So pelvic floor PT at the heart is really internal assessment for really pelvic floor specific problems. But it really is a sub niche inside of orthopedics and the physical therapy world in general.
That's great. Yeah, I mean, it's so important, and I agree. I mean, we learn so little about it. It seems like it's definitely an overlooked area. So I'd love to hear a little bit more. I love learning about people, about what got you into pelvic floor PT specifically. Like, tell us a bit about your background and how you found your way to this area.
Yeah, so I always had an interest in women's health. And I did have an opportunity to observe a little bit during school in a Hagerstown location. And it was just kind of that. It was like she saw a couple women's health. She put biofeedback on. She also did a little bit of lymphatic work and like oncological work. And I had very little exposure to it, but I always had this interest in it. And never really had an opportunity to have a clinical rotation in it. So I kind of ended up in PT just going the route of like typical orthopedics. Like I was an athlete in high school. And I kind of just fell in love with that part of just like movement as my job and not just movement for fun. And so I worked in some my first job was an outpatient orthopedic experience in a hospital-based system. And I did all the things, amputees, neurology. I did inpatient and outpatient. And then when I decided I really wanted to stick to outpatient ortho, and we were moving locations, I worked in a franchised type of private practice, where I didn't really have exposure to any of that. And really, they were not interested in pursuing that. And I wasn't really in a place to, because the pace of treatment is just so fast, which doesn't translate well to pelvic health care. So I kind of like over the couple years, I kind of like moved around in the outpatient ortho world until I landed in a really good situation here in West Virginia, where I had hour treatment sessions, I had an hour lunch, And like, it's really rare to find in our field where we get a solid hour with our patients anymore. So when I finally got there, I was able to pursue some of the education, and there was no program there. So they were on board with sending me to courses, and I was actually able to pursue it. But outside that, what really like drove that decision was me having my own kids. And so I had my first in 2015, and recognized some issues after that. I got some care, but it was like, okay, it was really based around fear and actually like limiting movement, which I found to be very stressful as an athlete. That like, it wasn't really about the promotion of movement. It was more like, well, you have this diagnosis, so you can't do this movement or this movement and wear this every day. And it was like very limiting and created a lot of stress. And as a PT, I was like, this doesn't really make sense. Like, why are we treating this condition without movement, but we're treating every other part of PT with movement? So it was strange. And then I had my second in 2018, and I had some more serious issues, I think, going on, even upwards of a year postpartum. And I couldn't find a provider, like, couldn't find one. And I live in the panhandle of West Virginia, and I ended up traveling to 2 different places, one in Virginia and one in Maryland. Had to take full days off work to be able to travel back and forth. And one was excellent. The other one, I think, fell short a little bit again. But the one that was excellent, I was like, oh, I can get better. Like, this makes sense. This is like evidence-based, and this is movement forward, and this isn't fear mongering. And so by the time my little one was 7 months old, I was in my first pelvic class, and I continued to take basically a class like every 6 months until I got my internal training and some exercise certifications. And it kind of just went from there. I ended up in my own private practice because I was just really sick of the medical system, to be honest. Even though I had that hour, I was constantly told I couldn't have materials. The patient care was not the priority. And I just felt like I was like swimming upstream all the time. And I just had an opportunity to jump, and I was like, well, I've jumped jobs a lot. So I really felt like that was the direction that I needed to go. But prior to that, I had never thought I was going to be a business owner. But it was really driven by like, this is what I love to do. I found this, and now I want to do it how I think it should be done, not how insurance companies or physicians think our job should be done. And so that's ultimately what really drove me out of the system, was just doing things better for people.
Yeah, absolutely. I was just talking to someone earlier today about, I feel like insurance doesn't allow for good care, unfortunately. Just the way it's set up, it's designed to fail.
Yeah. And even in that model, like, I had like the PT dream job, the 60 minutes and the, we'll send you to any course you want, and like all of the things. But when it really came down to like, this is what I need, and this is how I want to take care of my people, I still was not provided the resources to do that.
Right.
And I was like, I don't know, there's got to be another way.
Yeah. And you're making that way, which is awesome. So just basic question. I mean, what are some common signs and symptoms? I know we hear about, like incontinence and things like that, but what are, just some general signs and symptoms that might indicate pelvic floor dysfunction that people should kind of pay attention to?
Yeah, I think some of the obvious ones are the leaking and things people kind of understand, that is a sure sign of pelvic floor dysfunction. But I think some of the things that get lost are like frequency and urgency of urination. Constipation can be like a two-way street. It's like, what came first, the tight pelvic floor or the slow bowels? And slow bowel movements can cause pelvic floor dysfunction, or the other way around. Pelvic floor dysfunction can be the origin of difficult bowel movements. So painful intercourse is also another one that I treat a ton of, that really in mainstream medicine is not managed very well, and goes on way too long. Anyone with history of hemorrhoids, fissures, or any kind of rectal pain, tailbone pain is a big one. A lot of people tend to get chiropractic care and acupuncture and massage for tailbone pain, which are all good ways to manage that diagnosis. But I'm the only one that can internally assess and mobilize the coccyx. So I treat a lot of tailbone pain, and it's pretty successful with being treated with pelvic floor therapy. Tailbone pain, hip pain, heaviness or bulging in the vagina or perineal area. Also the sensations of like sitting down on the toilet and having difficulty starting your stream. Or if you like feel a trickle or hear a trickle versus a steady stream, those can be signs that we have some tight muscles around the urethral areas. Dripping when you stand up after peeing, or it's sometimes you're like on your way out your door to the bathroom and then you're like, wait, that just dripped out. That's something that I treat often, as well as any kind of like vaginal and vulvar pain that can be around the introital area. This creates a lot of pain with penetration. Also different kinds of vulvar burning with sitting, certain products like soaps, and other things like that. So yeah, I think the parts that kind of get lost in translation are the ones that aren't necessarily like vaginal or rectal oriented. So that hip pain, tailbone pain, sometimes like anterior pelvic pain. I treat cramping, like painful periods or painful ovulation are things that I can treat as well.
Awesome. Yeah, I think that's what I've loved sending people to you and working with you is, learning all the other aspects that I didn't even realize can help from pelvic floor PT. So it's so much, because there is so much happening down there. I mean, there's a lot going on. Yeah. So what is like one thing, maybe if you could boil it down to one thing, which might not be possible, but you wish more people knew about their pelvic floor?
I think so I do a lot of education in my sessions. And I think the thing that really blows people away the most is like, honestly, just the anatomy. Because most people think that the pelvic floor is like a muscle. And not only is it a muscle, it's actually like 15 to 20 muscles. And there's right and left side, and we can have dysfunction on one side and not on the other side. And I think that's like the biggest thing, is just that like the pelvic floor is not just a muscle that like squeezes to stop the flow of urine and then releases to open. It really helps with the function of digestion, toilet, and any kind of like intercourse or pleasure activity. And it can be treated by, sometimes the symptoms can be derived from like a single muscle of those 19 muscles. It's not necessarily like a whole problem. And I think that's what people are most surprised about, is that like we can actually separate it. Like you can have something going on the right side that's not happening on the left side, and front or back too. Now we can't necessarily like dissociate how to contract or not, front to back or right to left, but they can operate independently, subconsciously. So yeah, I think the anatomy just really blows people's minds.
And I love to, the whole, at least in our medicine, I know we talk about a lot, docere, doctor means teacher. So I think that is so important to like educate patients and people about, what's going on with your body, because it's so fascinating. It helps you, I think, feel more empowered by knowing what's going on. So that's great. How about, is there anything, I guess, on that note, like that would surprise us to know about, things that cause pelvic floor dysfunction or might exacerbate it? Like maybe, I don't know, common exercises or food or anything like that people don't think about that might cause pelvic floor issues?
Yeah, I think the biggest thing that I see are we call them just in casers. So these are the people that go to the bathroom frequently, but they're not necessarily always having the urge. Or maybe they are someone that does struggle a little bit with like urgency or frequency, but maybe it's not like controlling their life. They just know that as soon as they step foot in Target, they're going to need to use the restroom. So they're going to instead go before they leave the house, even though they don't have to go. But then when they get to Target, they still have to go anyway. So, so just in case peeing is a signal that kind of intercepts the normal neurological pathway between the brain and the bladder. So when we go just in case, when we go when the urge isn't present, it can perpetuate a false message, and it can perpetuate muscle tension, and it can perpetuate the early signal. So if you are going to the bathroom and your bladder is 70% full, then your brain is going to start registering that as, okay, well, she keeps emptying when I'm 70% full. I better give her an urge when she's 65% full. So then you start getting that urge sooner, and then you start going to the bathroom sooner, and then that interval starts really closing down. And at first, we might not recognize it. And we think that we're peeing just in case to make sure that we don't have to go later, or to make sure that we're not going to leak when we do that exercise at the gym. But peeing more frequently than the urge actually perpetuates the problem. And this is something that I see every day, to be honest, because people are told to listen to their bodies. And so their body's telling them they have to pee, and they're like, well, I'm just going to have to go pee. Right. But it really comes down to, it's honestly just like a behavioral training. And it might have taken them a long time to get to a point where that frequency starts impacting their life, or like their decisions around their activities. But it can be undone. It's just some behavioral training that I do. But yeah, I think that's one of the biggest things that I wish people knew, that that is actually perpetuating the problem that they're, sorry, bug in my face, that they're actually in my office for.
Yeah, that's interesting. I've never heard of that, but that totally makes sense from a behavioral physiological standpoint. So that is good to know. I have a few people in mind that I'm already thinking about that I need to talk to now. So I'd love to hear a little bit more about, which, I mean, you kind of mentioned it a little bit earlier about, your why, but like, what is your favorite aspect about, doing pelvic floor PT and specializing in it? Do you have anything that really stands out to you that you love?
I mean, I really think we are in a time in women's healthcare right now that is going through a lot of changes. And pelvic PT is it's not quite mainstream, but it is up and coming. And I think it's really powerful to be part of a movement to get women to know that there is care for them, and to be able to dissociate between like, that was bad advice and I need to go this way. Because there is still really outdated advice there. And I think patients themselves are starting to catch on of like, oh, like, why did they tell me that? I'm going to go look for a better answer. So I really think that we're like in a moment right now in the world that women's healthcare is making a lot of shifts. And ultimately, I think it is going to be a positive shift towards just creating empowerment and knowledge and awareness that like you can take care of these things, and it's not just a death sentence because you went through menopause or because you decided to have children. Like, does not mean that you have to pee your pants for the rest of your life, or have pelvic pain for the rest of your life, or go through surgical procedures. That's a whole other thing. But the interventions for women are not like, they're invasive. Like you go to them and they're like, my pelvis hurts, and it's like, well, okay, well, you can either drink wine and relax, or you can have a hysterectomy. It's like, there's no other options. And clearly there are. And so I think really just starting to get the word out, and not only to patients, but really to those other providers. Like they really are the ones that are gonna need to recognize when to refer out. And that's an uphill battle of us. My profession is just getting that information out there. But I think the biggest part is just literally empowering women every day and making them recognize like this can actually improve. I don't have to take this medication forever.
Absolutely. I know I've seen it myself. I mean, I'm sure, everyone on the call has maybe seen it of, my whole thing is just believe women and, how many things, yeah. Oh, it's painful. Sorry. I mean, that's just sex is painful, like suck it up kind of. So it is really great to see that, women are kind of standing up for themselves and being better advocates, which I hate that we have to be better advocates, but, I definitely see that shift too, which is, I think we're just at the beginning, which is great. So one question I do want to ask, because we've all heard about them, are Kegels. Are they really that beneficial? Does it maybe depend on the situation? Give us like, where do we stand with Kegels nowadays?
Yeah. So the pendulum has definitely swung, right? And so I would say like the overwhelming answer to that question is that they're not really that important. They're rarely part of my treatment plan. And when they have a purpose and they're coordinated. So the pelvic floor never works alone, I think is the important thing. And so when you are doing a Kegel-based program, you are contracting a single muscle group and letting go a single muscle group. And that is not how the pelvic floor works. Like when you go for a run, like your pelvic floor is not working on its own. When you pee or poop, the pelvic floor is not working on its own. So it's rarely ever working in isolation, yet for some reason, the treatment has been, well, let's strengthen this muscle. And I would say like 70% of my population actually deals with tension and increased tonicity of the pelvic floor rather than like a true absolute weakness and like lengthening or like a collagen deficiency in the pelvic floor. So I would always tell women they shouldn't be just doing them routinely. Like you wouldn't just be like sitting at the kitchen table doing bicep curls. Like it's another group of skeletal muscles that should have its own time and place and be coordinated with a functional activity. So some of the best pelvic floor strengthening or pelvic floor coordination is going to look like squats and deadlifts, and like big functional tasks, but coordinated with awareness. And I think there's a time and place, but I really think that is where it deserves an internal assessment. And that is what I think differentiates us from like a provider that's like, oh, you're leaking? Well, you should just do your Kegels. You had a baby a year ago. It's like, no, the majority of women who come into my clinic actually have increased tension and tightness, like, and they might be weak. That might be right. But you can't strengthen a tight muscle. Like there has to be a continuum. So yeah, and 70% of women actually do them wrong anyway. So they're usually not as helpful as people believe they used to be.
All right, I'm glad we have that Kegels all straightened out now. And then my last question, and if we have time for some questions, we can get to them at the end. Again, if you have questions, please put them in the chat. I do see one, which I think we will definitely be able to get to. You mentioned, the training is like post-doc, and additional courses and things like that. So I guess, and feel strongly about asking this question just in my own profession. I think in alternative medicine, there's a lot of different things people do, but the training it varies from practitioner to practitioner. So like, how do you know how to find a good pelvic floor PT? Are there certain questions you should ask like regarding their training? Like, is it standard across the board? Like, how can, I guess, women be better advocates in that they find a good person to work with?
So we don't necessarily have to have any certification or anything postdoctorally. So it's not that you need to look for a particular certification, but what you do need to look for or ask is, are they a pelvic floor specialist? Like, have they taken that coursework? And that particularly includes an internal exam. Now, there are a few pelvic or orthopedic PTs that had internal training and have chosen not to do internal treatment. They tend to be more in the sport performance world. And they have internal PTs that they refer to. But if the practice does not have a provider that has been trained to do internal examination, then that is not a provider, that's a pelvic floor specialist. And they may have a generalized understanding, but they cannot assess if those muscles are weak or tight, like, or stretched out or tight. Like, they cannot assess the quality of your Kegel if they are not doing an internal exam. So that's like the first and foremost, the most important thing. As far as quality of care, I always suggest at least an hour appointment. This is a lot. I spend about 30 minutes just talking to my patients on the initial evaluation. And I don't even complete the initial like assessment of all the body parts in the first time. It usually takes 2 or 3. So if your appointment is any less than 60 minutes, you're gonna have a really hard time getting your whole story out and having like a really thorough exam, really from head to toe. I mean, I look at, mid back and foot and hip mobility and spine mobility. Like, it is really, truly, I have a hard time doing it in 60 minutes. There's really no way that someone is doing that in 30 or 45 minutes. So from a quality of care standpoint, that person could be a great PT, but they really need the time allowed to be able to give you a good exam. And then I think you also need to ask, like, who is leading the treatments, especially the subsequent treatments. So is it in an environment where you only see the PT every single time, and that's a pelvic floor specialist, and you get all your treatment time with them, versus are you going to be handed off to a PTA? There are PTAs that can be well educated in pelvic floor. I don't know any locally, but also, are you going to come in and then be in a gym room full of people with also like knee replacements and shoulder surgeries? And is that going to be driven by like a PT directed plan of care, or is that you're doing exercise with a technician or an assistant who wasn't the one actually doing your internal? So I think who is running your plan of care is really important. What dissociates a PT from a PTA in tech is the level of education has at least a minimum of 5 years difference between a PTA and a PT. And that means that there's constant assessing going on. And I believe that constant assessment has to be going on in the pelvic floor to be able to drive a good plan of care. So, and along the lines of like, what are the people, what does the PT schedule look like? Like, are you in that gym full of other people and you're laying on a table doing your Kegels while the guy next to you is strengthening his rotator cuff? Or are you in a private room working with your person where your person can give you, specific cues towards your pelvic floor? I think it's important. People, I think, appreciate if they're being seen for pelvic floor to not be in a gym full of other people not being seen for pelvic floor. It can be a little bit
very personal thing. Yeah. Definitely.
I think those are the main things. And I also tell people, I mean, there are people that decide to not work with me, and I always tell them, like, they should be seeing results in 3 to 5 visits. And not that they're going to be better in 5 visits, but they should be seeing results in 3 to 5 minutes. I have had way too many women go to 12, 15, 20 appointments where they're getting the same treatment over and over again, and they come out and their symptoms are not better. And they just like went through the program because that's what they were told to do. If you're not seeing change, the PT should be changing the direction of their course of treatment or looking somewhere else in the body. Maybe, get this, outside of the pelvic floor. And so yeah, I think you do not need to go 2 or 3 times a week for 12 weeks. Like, that is a very old school, money insurance driven plan of care. You should be seeing results, change happen, hopefully immediately, but depends on how long you've had symptoms. But you should be seeing some pretty major changes in 3 to 5 visits. And if you're not, then you need to truly consider, like, am I getting the best care or the best quality care in this setting?
Mhm. Those are all great questions. I mean, that is super helpful to know because, yeah, there's not a lot of you out there. So it's good to know like who is good and who's not and how to figure that out. So it's great. So looks like I have one question. I mean, we'll end in a couple minutes, but if anyone has anyone else, get them in now. One person wanted to know if you work with both men and women.
So I do not. I've as I was going through my coursework, I really had because of my story, I had a passion for prenatal and postpartum. So I did not continue the coursework for men. But I do have resources for people both in Maryland and West Virginia. If they have males in their life that do need referrals, I do have resources.
That's great. And on that note, I mean, yeah, how would people get in touch with you or just go to your website if they wanted to work with you potentially?
Yeah, the website is probably the best place to start. I either get inquiries through phone or the contact page on the website. I am on social media as well. But yeah, phone call is probably the easiest way to like get in and get scheduled the quickest.
That's great. And your website is Gaia Women's PT, right?
Yes.
Yes, I have it memorized. I've referenced it so many times for people. Well, good. Well, looks like we don't have any other questions right now.
Okay.
So I think we'll end. Do you have any other last parting thoughts before we wrap it up for today?
No, I think that's good.
Awesome. Well, again, thank you so much for talking to us. I mean, I learned stuff, which I love learning. So I'm glad we talked to you. Yeah, I'm sure be in touch soon. And thank you everyone for attending. Yeah, I will get this, I guess, posted for other people to watch because I know some people couldn't attend. So thank you again, Dr. Gise.
Sounds great. Thank you so much.